So today we are talking about the practical tips of laser tissue interaction and how to optimize laser parameters, and I think this is a very important part of the laser practice, because if you understand the basics, then we are going to be able to be more creative, improve the outcome of our treatments, the efficacy is going to be maintained, and the incidence of side effects will be much less. My name is Ashraf Badawi. I am the Vice President of the European Society of Lasers and Energy-Based Devices, and at the same time I am a consultant for Clarion. I'm very happy to work with them while they are trying to improve the standard of practice in this field. And also I am the author of a textbook called The Practical Manual of Laser Applications in Dermatology. So when we talk about laser, it's very important to know that laser is part of the light spectrum, and the light spectrum is part of the electromagnetic spectrum. This electromagnetic spectrum starts with the cosmic rays, the X-ray, and then the ultraviolet. And then we have the visible lights, then we have the invisible lights, and then it will end up with the microwave, the TV and FM radio waves, and then the AM radio waves. Why this is important? Because this spectrum is going to split into two major parts: the ionizing radiation and the non-ionizing radiation. This is very, very important because many people who are getting the laser treatments, or sometimes even the practitioners, are asking if there is a limit for the laser exposure. As long as the laser is lying in the non-ionizing radiation, then there is no limit for the exposure. It is safe, and it is different than the ionizing radiation, where we have to have limit for the exposure. With ionizing radiation, with the X-ray, for example, people working in the field of the X-ray, they cannot be exposed to the laser without a limit. After a certain limit, they have to stop the exposure to the X-ray. They have to have a break, and then when it's safe, they can return to work and be exposed again. But with the laser, because it's non-ionizing radiation, there is no such limitations. On the other hand, the laser is differentiated into visible spectrum and infrared lasers. And here there are two important practical issues which we need to raise. Number one of the contraindications which we always read in the laser textbooks is the photosensitivity. So if someone is having photosensitivity, there is a precaution regarding the laser, and some textbooks and some laser machine manuals are claiming that it's contraindicated to use the laser. However, this is something which needs to be verified, and we have to think a little bit deeper about it. For example, if someone is doing laser hair removal with the diode laser or the Nd:YAG laser, those are infrared lasers, and for the skin, this is not a visible light. When someone is having photosensitivity or taking medications for photosensitivity, usually this is linked to the ultraviolet exposure, not to the infrared. With infrared lasers, this is actually for the skin, this is considered as heat and not light because it's infrared. With the visible lasers, it can carry a risk. However, again, the photosensitivity is usually linked to the ultraviolet and not even to those visible lasers. On the other hand, if the procedure we are doing is causing a wound in an area which is exposed to the light, for example, the face or the hands, then healing of that wound might be associated with hyperpigmentation if the patient is having photosensitivity. So if we are using ablative lasers, MELANIN or CO2, or if you are doing tattoo removal with lasers which are causing wound for a patient who is having photosensitivity, if that patient did not use the appropriate sun protection, then they might develop hyperpigmentation. So this is something which we have to be careful with. On the other hand, when it comes to laser safety, if someone forgot to wear the goggles while working with one of the visible lasers, the 532 or the dye laser or the ruby laser or the alexandrite laser, they are never going to forget it again, because the strong flash of light or the laser will give the impression that something wrong happened. So in many cases I receive a phone call from some colleagues asking me if they need to see an ophthalmologist because they forgot to wear the goggle while they were firing the KTP, the 532 laser or the dye laser. And usually it's not a big deal. However, when we are working with the infrared lasers, the 1064, the Nd:YAG, we have the false sense of security because we are not seeing the laser, so we think it's safe. Whereas those lasers are deep in penetration and we are not even having the chance to blink. With visible lasers, because of the strong flash of light, we blink, which is a protective mechanism. But with the lasers which are infrared, which we cannot see, we don't blink. So everything can go deeper, and that's why the Nd:YAG laser, for example, is associated with the higher or the highest incidence of accidents and problems when it comes to laser safety. And that's why I do strongly encourage everyone using the laser to wear the appropriate eye goggles, whether they are seeing the laser or not seeing the laser. And when they are not seeing the laser, it is even more important than when we are working with visible lasers. But eye goggles to be used appropriately is a very important safety measure with the laser. We have different types of clinical lights. We have the ultraviolet, we have the visible light, we have the infrared, and we have the mid-infrared. So in order to generate those lights, we can use lasers or pulsed light devices, which are the IPL systems. What is the difference between laser and light or IPL? The laser is coherent, collimated, and monochromatic, whereas the other light sources are non-coherent, non-collimated, and polychromatic. If we look at each of those terms and we understand it, then we are going to be able to appreciate the difference between laser and light. So when it comes to the coherence, coherent light means that all the waves forming that light beam are starting at the same point and ending at the same point. So this is going to create a waveform, and this waveform is identical for all waves composing that light beam. And this is the meaning of coherent. The physicists are calling this term in phase, which means that each wave is going to be in the same phase with the other waves composing that light beam. So this is the coherence. And what is the clinical importance of coherence? The standardization. When we are using the laser, then each pulse is going to exert the same effect like the other pulses because it has the same physical characters like the other pulses. When we are working with non-coherent light, it's a little bit different because each waveform is a little bit different in shape, and each pulse is having a little bit different physical character than the other pulses, and that's why we might have different effect with the same parameters when we are using the IPL, but with the laser it's more standardized. The second character of the laser is being collimated, and collimated means that the waves forming that beam are going parallel to each other, and in this case it is going to be traveling long distances with minimal divergence, and hence we are able to use the lasers as pointers in the lectures, where the light beam can travel or the laser beam can travel long distances without any problem. And also in the wars they have been using the laser guided missiles, where the pilot can aim a laser beam towards a certain target on the ground, where the missile is going to travel that distance without divergence, without missing the target, and it will be able to hit the target specifically without going around. Clinically, collimation is very important because sometimes we have targets which are deep in the skin, like dermal pigmentation or deep hair follicle or deep blood vessels. In this case, the collimation of the laser will ensure that we are able to transfer enough amount of energy into the deeper layers of the skin. And that's why collimation is an important character of the laser, and it differentiates it from other light sources, including the light or the IPL. So the non-collimated light will not be able to treat dermal structures hair follicles if they are deep, or dermal pigmentation or tattoos which are in the derms, or even deep vascular lesions. The third character of the laser is being monochromatic, and monochromatic means it's composed of one wavelength. So if we are saying it is Nd:YAG, then it's 1064, Alexandrite 755, KTP 532, and so on. And this is important because when we are able to know specifically the wavelength we are working with, we are going to study the absorption curves, and we are going to define what are the chromophores or the structures in the skin which will interact with that particular wavelength. Whereas with the IPL, which is polychromatic light, we are not in control. So we have different wavelengths which are coming out. They are going to hit different chromophores, and we cannot control precisely what is going to be the interaction. So this is the difference between the laser and the IPL or other light sources. This is just a summary which is showing the difference between the sunlight, the IPL, filtered light, and the laser. So with the sunlight, we can see that it is polychromatic. It's composed of the whole spectrum. It is non-coherent. We can see that each waveform is different than the other waves in the same beam of light. And of course, it's non-collimated, and that's why the sun lightens half of the earth at a time. On the other hand, this is the filtered light, the light source, and then there is a filter to cut off some of the wavelengths, but again it's polychromatic. It's composed of different wavelengths. It is non-coherent. We can see that each waveform is a little bit different than the other waves, and of course it's non-collimated. That's why usually the spot size of the IPL is a little bit large. Then we have the lasers, which is monochromatic, composed of one single wavelength. It is coherent. We can see the waves are of the same form and the same shape, and of course it's collimated. So this is the difference between the three different light sources: the sunlight, the filtered light or the IPL, and the laser. For the laser tissue interactions, it's very important to remember that when we apply a laser beam towards the skin, part of the energy is going to be reflected from the surface of the skin. Another part is going to be scattered from a deeper layer. Then there is an absorbed portion of the laser beam, and this is a very important part. This is the part responsible for the effects we would like to get. Finally, there is forward scattering, and a small portion is going to be transmitted without any of those interactions. This is very important to know because as laser practitioners, it's very important to try to be able to minimize the reflection and scattering so that we have more energy available for absorption. If you are able to do that, then we can use less energy to achieve our goals. When we are using less fluence or less energy, then the incidence of side effects or the pain associated with the treatment is going to be less, and our treatment is going to be more effective. How can we decrease the reflection and scattering? Actually, there are two important things which we have to do. Number one, we have to work on a clean surface. So if the skin is cleaned from makeup, from sweat, from sebum, from skincare products, then the optical penetration of the laser is going to be much better. There are some studies which are showing that if the patient is going regularly on retinol products, retinol containing products, or doing microdermabrasion regularly, then where the optical penetration of the laser is going to be much more effective. And in this case, it is wise to use a little bit less energy because the treatment is going to be effective even with less energy and will not cause any pain or problems. So this is something we have to keep in mind. The other important thing is that when we are using the laser handpiece, it's very important to hold the handpiece perpendicular on the surface of the skin. This is going to be associated with less reflection and scattering because the perpendicular beam of light is going to be associated with less scattering and reflection. So it's very important to always hold the handpiece perpendicular on the surface of the skin so that we are ensuring that most of the laser is going to be penetrating into the depth of the skin with more energy available for absorption. So those are important practical things which we have to keep in mind with the laser tissue. It's very important to differentiate between two important terms, target and chromophore. When we are talking about hair removal, the target for the hair removal is the hair follicle. However, the hair follicle structure is colorless. So we have the bulb and the bulge. Those are cells containing protein, and they don't have a color. So if we aim a laser beam towards the hair follicle, which does not have a color, there is no interaction. So that's why we have to find a chromophore, and chromophores are structures in the skin which can absorb the laser or the light and interact with it. So in this case, we have to find a chromophore which is close to the hair follicle, so that this chromophore is going to absorb the laser, convert it into heat, and the heat is going to damage the target. So if we are trying to treat white hair, the treatment is not going to be effective because it doesn't have a chromophore. In case of hair, we are trying to target the follicular melanin, which is going to absorb the laser, convert it into heat, and then the heat is going to be spread towards the bulb and the bulge of the hair follicle, damaging the stem cells there. This is the principle and the theory of selective photothermolysis. What about the blood vessels? The blood vessels, again, when we are trying to treat vessels with the laser, the objective is to damage the intima of the blood vessel wall. So this is the target, but this is again a structure which does not have a color. So we have to find a chromophore which is close by, and in this case is going to be the oxyhemoglobin, which is going to absorb the light or the laser, convert it into heat, and damage the intima of the blood vessel, which is the target. That's why if you are having a contact cooling device, and if you press too much the blood vessel you are trying to treat, you are squeezing the blood out, and if that happens, then the pulse of the laser or the light, the IPL, will not be effective because there is no chromophore. So again, this is very important to remember. So we have different chromophores in our skin. We have the oxyhemoglobin, which we target for treating blood vessels; melanin, which we target for treating benign pigmented lesions or for hair reduction; water, which we target for rejuvenation; and then we have the tattoo ink, which is considered exogenous chromophore, and this is what we target when we would like to get rid of the tattoos. According to the effect which we are going to get, we might have different laser tissue interactions. So we might convert the light into heat, and this is called photothermal effects. And according to the temperature rise, we are going to have different photothermal effects. So if we get low temperature, then this is going to cause photobiostimulation, increasing the local blood circulation, increasing the mitochondrial activities, production of more DNA and energy, more ATP and energy by the mitochondria, and stimulating the fibroblasts. So this is called photobiostimulation. If the temperature rise is high, then we get photothermolysis. Photo means light, thermo means heat, because we are converting the light into heat, and lysis means destruction. So we are able to destroy certain structures, like in cases of hair. So in hair reduction, we are getting photothermolysis. If the temperature rise is higher than that, then we get photocoagulation, because in this case the heat is going to be above 60 degrees Celsius, and this is going to lead to coagulation of the structures we are working on, like in cases of treating blood vessels or warts. In this case, we are using higher fluences in order to achieve higher temperature and get photocoagulation. What if the temperature was above 100 degrees? Above 100 degrees, which is the boiling point of water. If we get temperature above that, then we are going to get vaporization. Vaporization means ablation, and we are removing layers of the skin by ablation or by vaporization. And this happens when we have wavelength, which is very highly absorbed by water. So the temperature is going to be much higher than the 100 degrees Celsius, and in this case we are going to get vaporization of the tissues which we expose the laser for. So this is the photothermal effect. Also, there is another laser tissue interaction called photomechanical effect, and this is what we are using for treating benign pigmented lesions and tattoos, where we are using the Q-switched lasers with very short pulse duration, and this short pulse duration is going to be associated with higher peak power. With the higher peak power, we are going to get this photomechanical effect and explosion. So the ink particles are going to be fragmented into small particles, which are going to be removed from the tissue, and the same happens if you are treating benign pigmented lesions. The ink, the melanin is going to be fragmented into small fragments, and those small fragments of melanin are going to be phagocytosed and removed from the skin, which is a process which takes longer time, and that's why an interval of 6 to 8 weeks is required in between the sessions. Finally, there is something called photochemical laser tissue interactions, where we are using the light to excite a chemical reaction, and this chemical reaction is going to result in singlet oxygen production, and this singlet oxygen is having a lethal effect on the pathological tissue, whether it's local malignancy or certain pathological skin disorders like AKs, actinic keratosis, or in some cases of acne. So in this case, we don't depend on the thermal effect, we depend on the chemical effect, where the light is going to excite and stimulate a chemical reaction in order to damage the cells containing the photosensitizer in order to cure the condition. With a selective photothermolysis, it's a principle where we are aiming a laser beam towards the skin. The laser beam should be blind for everything except for its target. So if we would like to target those two blood vessels, then we aim a laser beam towards the skin. It shouldn't see anything on the surface of the skin. It shouldn't see the melanin in the epidermis. It shouldn't see the melanin in the hair follicle. It should only see the blood vessels which we are trying to target. In order to achieve that, we have to use the right appropriate wavelength, which is going to be selectively absorbed by the hemoglobin in this case, or the oxyhemoglobin. And we should use the right energy. If we use the right energy, then we are going to get selective photothermolysis. If we used too high energy, then the heat generated is not going to be confined to the target, but it's going to be excessive, so it's going to damage the target, and also the damage is going to go to the surrounding tissue, and in this case we are calling this non-selective photothermolysis, and that's why the energy shouldn't be too high. On the other hand, if you use too low energy, then instead of getting selective photothermolysis, we might get something called photobiostimulation, and in this case someone will come to achieve hair reduction with the laser, but then they go home and come back complaining that the hair increased. This is called paradoxical hair growth. Why? Because if the heat or the energy used was too low, then it's not going to cause selective photothermolysis, but it's going to cause photobiostimulation, and the hair might increase. And that's why using the appropriate energy is a key in order to optimize the outcome of the laser treatment. Finally, pulse width is a very important parameter of the laser, and it's very important to use the right and the appropriate pulse width or pulse duration to achieve selective photothermolysis. And this is something which we are going to throw some light on in the coming few minutes. This is a nice experiment which we do to show the selectivity of the laser. In this video, we have two balloons, a dark balloon inside and a light balloon outside. As we fire the laser, it is going to go through the light balloon without any interaction because there is no chromophore, and it's going to hit the dark balloon, and the dark balloon is going to rupture. Let us see the video again. So we have seen, practically speaking, we are seeing that in two examples. Number one, after doing hair removal, we are getting something called perifollicular edema. With the perifollicular edema, we see that there is edema confined to the hair follicles, whereas the skin in between is intact. Why? Because the heat is going to be confined to the hair follicles, and this is our target. On the other hand, another example, if we have all the settings, the parameters set for hair removal at a certain patient, and then we fire a laser pulse on an area of the skin which does not contain any hair, the patient will feel nothing. However, if we fire the same pulse on an area which is having thick hair, the patient is going to feel heat. So again, this is showing the selectivity of the laser and the principle of selective photothermolysis. So we have certain parameters in order to optimize the outcome, and those parameters are the wavelength, which is determining what is going to absorb that wavelength or that laser, the fluence or the energy input, the pulse duration or the energy flux, the spot size, which is going to affect the penetration depth, and then also we are using cooling of the skin in certain applications, and we don't use cooling for other applications. So we are going to discuss each of those parameters in the next few slides. Just a quick example of what we are trying to do is in laser hair removal, we have a target which is the stem cells in the bulb and the bulge of the hair follicle. Those are colorless structures. The chromophore is the melanin in the hair shaft. So we would like to aim a laser towards the chromophores. The chromophore is going to absorb the light and convert it into heat, and the heat is going to radiate to the target to damage the target. So this is what we are trying to achieve here. When we are talking about laser assisted hair removal or hair reduction, we have a challenge because we are picking a laser which is absorbed by melanin. This melanin is present in the hair follicle in order to be absorbed, to absorb the light and convert the light into heat so that we can damage the bulb and the bulge of the hair follicles. But when we are trying to treat someone with dark skin, also there is high concentration of melanin in the epidermis. So the challenge becomes, how can we make a laser pulse go through the skin without affecting the melanin in the epidermis and going to the hair follicle and affecting the melanin in the hair follicle. This is a challenge, and we have different ways. When we look at the history of lasers used for hair reduction, ruby laser was one of the first lasers used because it was the highest wavelength to be absorbed by melanin. But this was used in treating skin types 1 and 2. When trials were made to treat darker skin types, it didn't work well because the melanin in the epidermis was significantly absorbing the ruby laser, and we used to get side effects. But also the efficacy of the laser was not as good as in first skin because most of the laser was absorbed by the melanin in the epidermis. So before going to the hair follicle, the laser was consumed. That's why the alexandrite laser was introduced to treat darker skin types. It is safe and effective up to skin type 4. However, for darker skin types, the diode and the Nd:YAG lasers were introduced, and we can see that the absorption of the diode and the Nd:YAG lasers are less than the alexandrite, and because of that they can penetrate deeper into the skin. Why the Nd:YAG and the diode are safe in dark skin? Because we have a rule in the laser which is saying that the smaller the chromophore size, the less it absorbs the laser. So when we compare the epidermal melanin size to the follicular melanin size, we'll find that the epidermal melanin size is much smaller, so it's not going to absorb those types of lasers, the diode and the Nd:YAG, as much as the hair follicle melanin. So in this case, if you are using the Nd:YAG or the diode laser, it can bypass the epidermis. It passes by the epidermis without any effect, and it goes to the hair follicle, which is large melanin particles, and in this case the effect is going to happen without damaging the epidermal melanin. Having said that, it's important to know that the Nd:YAG and the diode, once the hair is becoming finer and thinner, then it's not going to be as effective as other wavelengths because of the less absorption by melanin. Of course, there are some laser companies like Photona who were able to tailor the pulse duration and change the pulse duration so the Nd:YAG laser can be effective even in fine hair, but this is a very special case. Not any Nd:YAG laser can achieve that. When it comes to vascular lesions, also there are some particularities regarding the vascular. So again, we have to look at the absorption curves. The absorption curves are curves showing the different chromophores in the skin, the hemoglobin and oxyhemoglobin, the melanin and the water. And then we have the absorption coefficient. So the higher we go, the higher absorption we have, and the lower we go, the less absorption we have. And those are the different wavelengths which we can use with different types of laser. So if we look at the oxyhemoglobin, we are going to see different peaks of absorption, and that's why we have different wavelengths used for treating vascular lesions. So if we have superficial vascular lesions, then we can use the pulsed dye laser, where this is a wavelength which is highly absorbed by oxyhemoglobin, so it can work on superficial vascular lesions. However, if we need to treat deep vascular lesions, then we have to use the Nd:YAG, because the Nd:YAG is a wavelength which is highly penetrating into the skin due to the low absorption by the chromophores, so it can penetrate deeper. So for deep vascular lesions, we need to use the Nd:YAG, whereas for superficial vascular lesions, we can use the IPL or the pulsed dye laser. For pigmented lesions, again, we have the different options. So if you are trying to treat both epidermal and dermal pigmentation, then we have to use the Q-switched lasers, Q-switched Robi, Alexandrite, or Nd:YAG, or even Q-switched KTP. Q-switched means quality switch. This is a switch inside the laser cavity, which is allowing the laser to come out only in very short pulse duration, in the nanoseconds. Those are using a mechanical effect, so photomechanical effect, and that's why they can penetrate up to the dermis, down to the dermis, and exert effect on both epidermal and dermal pigmentation. Whereas if you are using longer pulse lasers like frequency double Nd:YAG or long pulse Alexandrite, those lasers are highly absorbed by melanin, but because of the fact that they depend on thermal effect, they can work only on epidermal pigmentation. They cannot affect the dermal pigmentation. What about resurfacing? For resurfacing, we are depending on the absorption. So again, if we look at the absorption curves, we are going to see that resurfacing means ablation of the surface of the skin, which requires very high absorption of the wavelengths by water. And in this case, we have two main players for the resurfacing. We have the MELANIN 2940 nanometer wavelength, or the CO2, which is the 10,600 nanometer wavelength. And there is a difference between those two wavelengths. We can see that the erbium is about 15 times higher in absorption by water than the 10,600, the CO2, and that's why the MELANIN is known to be safer, associated with less downtime, but also less effective than the CO2. Histological studies with the different lasers, we can see that with the CO2, after the ablation, we can see that there is a thermal zone of 150 microns. This is micron, not millimeters, of thermal damage, which is responsible for the effectiveness of the CO2, but also the prolonged downtime and the side effects which can happen with the CO2. With the MELANIN, after the ablation, we get a thermal zone of 15 microns, this is associated with better safety profile, less efficacy. And that's why the laser companies were able to play with the pulse duration of the MELANIN. So now we have the long pulse MELANIN, which is associated with tailoring the pulse duration so that we can get whatever effect we want. If we want to have a medium or moderate effect, thermal effect, which is less than the CO2 and more than the MELANIN, then we are using a long pulse MELANIN, which is allowing the thermal diffusion to exert some thermal effect in the tissue, which can go up to 90 microns in the tissue, which is significantly more than the MELANIN, the short pulse MELANIN, and less than the CO2. So this is going to be associated with good efficacy and much less side effects than the CO2. So today we are able to use with the MELANIN different pulse durations to allow tailoring the effect. If we need to just ablate, then we use short pulse duration so that the thermal effect is almost nil. If we need more aggressive effect and deeper effect, then we use extensive pulse duration. And if we want something in between, then we are using moderate or medium pulse duration. This is something we can control today when we are playing with the ablative lasers, so that we get different laser tissue interaction according to the desire of the operator and the treating physician. So this was regarding the wavelength. What about the fluence? Actually, the fluence is going to be determined according to different factors. One of them is the aim of the laser treatment. Another one is the application we are using the laser for, then the laser type or the wavelength, the target size, and the skin color or the skin type. Regarding the aim, if you would like to achieve photobiostimulation, then we don't need high fluence. Low fluence will do the job. In selective photothermolysis, we need high fluence because we need to damage a certain target. So high fluence is going to be required because this is going to achieve the destruction in the tissue we'd like to target. If we are using the laser for photochemical effect or the PDT, photodynamic therapy, then in this case we don't depend on thermal effect, so low fluence will do the job. For the applications, we can use the Nd:YAG laser 1064 for rejuvenation. In this case, we might be using a fluence ranging between 12 to 15. Remember that this is photobiostimulation. That's why we are using low fluence. We can use it for hair reduction, which is selective photothermolysis, and in this case, it's going to be ranging between 25 to 50 joule per centimeter square. If you are using the Nd:YAG for treating vascular lesions, then the fluence can go up to 160 joule per centimeter square, because here the effect is photocoagulation, photothermal, and we'd like to achieve some coagulation of the blood vessels, and that's why we have to use higher fluence. So again, the fluence is going to be changing according to what exactly we need to achieve and what is the application we are using the laser for. The laser type will also play a role regarding the fluence. So in hair reduction, I can achieve hair reduction with the Nd:YAG, and in this case I would use 25 to 50 joule per centimeter square. I can achieve hair reduction with the diode laser, and in this case the fluence might range between 20 to 40 joule per centimeter square, and I can achieve the hair reduction with alexandrite, and in this case the fluence is going to be between 12 to 20 joule per centimeter square. Why the alexandrite would require less fluence than the Nd:YAG, for example? Because the alexandrite is higher in absorption by melanin, so less fluence will do the job, whereas the Nd:YAG, because of its low absorption by melanin, we have to compensate the low absorption by increasing the fluence. The target size is another factor which is influencing the fluence we have to use. So if you are trying to treat large target, then low fluence will do the job. Large target will absorb significant amount of energy, and that's why low fluence will be sufficient. It's going to achieve the objective, and the side effects and the pain is going to be less. Whereas small targets will absorb less lasers, so in this case we have to use higher fluence. So if you are treating someone who's having thick hair, then low fluence, you can start with low fluence and the treatment is going to be effective. After a few sessions, when the hair is becoming thinner and finer, then you have to increase the fluence gradually, because the absorption is going to be less. So this is very important to keep in mind. The same applies for the vessels or the tattoo or the benign pigmented lesions and so on. Skin type. If you are using the laser for laser assisted hair reduction, in dark skin we have to reduce the fluence, otherwise we are going to damage the skin. But in fair skin, you can increase the fluence if required, which means if you are treating a patient with fair skin and the hair is thick and dark, then low fluence will do the job. When the hair is becoming thinner and finer after a few sessions, then you have a free hand to increase the fluence because the skin is fair, it is safe. If that happens in dark skin, you have to be cautious, you have to be careful. Otherwise, if you increase the fluence, you can damage the dark skin. So this is the difference. When it comes to vascular lesions, if you are trying to treat veins in fair skin, you have to use less fluence. Why? Because in fair skin, the skin is transparent and the energy will penetrate deeper into the skin. So if you are using high fluence, especially with the Nd:YAG laser, then high penetration with high fluence, this can cause scarring. So if you are trying to treat vascular lesions in fur skin, it's very important to keep in mind that you have to be a bit more conservative with the fluence. What about the pulse duration? Pulse duration is a very important factor or parameter of the laser tissue interaction, and it's very important to understand how to navigate with that. But before going to the pulse duration, it's very important to know that there are certain pulse durations we have to be familiar with when we are dealing with the lasers. For example, continuous wave lasers are lasers which are going to be emitted as long as we are pressing the foot switch, and it is not a very popular type of pulse duration now. It was one of the first pulse durations associated with the CO2 lasers 30 years ago, and this was associated with significant amount of scarring because it causes a lot of collateral thermal damage, so you are not very selective. That's why it's not very popular now. So this is the continuous wave. Then we have the Q-switched lasers, which is having nanosecond pulse durations, and this is what we are using to treat tattoo, to remove tattoos and to treat benign pigmented lesions. In this case, the pulse duration is so short with very high peak power, and this will cause photomechanical effect fragmentation of the ink particles in case of tattoo, or the melanin in case of benign pigmented lesions, and then those fragments are going to be phagocytosed and removed from the skin. Then we have the pulsed lasers, which are usually in microseconds or milliseconds, and those are the most popular lasers we are using in our practice. Then we have picosecond lasers, which are becoming more popular now for treating pigmented lesions and tattoos and some other indications as well. And then we have the femtosecond lasers, which are so far used in ophthalmology treatments, not in the dermatology. So those are different pulse durations which we are using with different types of lasers. Now, regarding the pulse duration, in order to adjust the pulse duration, we have to be familiar with a term called thermal relaxation time. What's the thermal relaxation time? It's the time necessary for the target to cool down 50% through the transfer of its heat to the surrounding tissue via thermal diffusion. So this thermal relaxation time is something linked to our structures and our chromophores, and has nothing to do with the lasers we are using. To clarify it more, if we have here a target exposed to the laser, with the beginning of the laser pulse, the temperature will start to rise till it reaches the maximum, and then at a certain point it's going to radiate the heat to the surrounding tissue, so the temperature inside that target is going to diminish, it's going to drop. When the drop goes down to 50% of the acquired temperature, this is called the thermal relaxation time. So the thermal relaxation time is the time required by the target to cool down 50% through transferring the heat to the surrounding tissue. And why this thermal relaxation time is important? Because before we reach the point of the thermal relaxation time, the target is containing more than 50% of the heat, but after the thermal relaxation time, the target has lost most of the heat, more than 50% of the heat, to the surrounding tissue. So if you would like to achieve a certain effect on a target, we have to define what is the thermal relaxation time for that target and use a pulse duration shorter than the thermal relaxation time. In order to skip any effect on that target, then we have to use a pulse duration longer than the thermal relaxation time of that target. So this is the principle of thermokinetic selectivity. If we look here, we are going to see that the same chromophore, according to the size, might have different thermal relaxation time. So the epidermal melanin, because it's small structure, its thermal relaxation time is ranging between 3 to 10 milliseconds, whereas for the hair follicle it's 40 to 100 milliseconds. So this is very important to observe. Also the blood vessels, if you are trying to treat small fine blood vessels with 50 micron diameters, the thermal relaxation time is 1 millisecond, whereas for 100 micron blood vessels the thermal relaxation time is 5 milliseconds. So again, the thermal relaxation time is going to be different according to the size of the chromophore. If we would like to exert an effect on epidermal melanin and the thermal exchange time is 3 to 10 milliseconds, then in this case I have to use a pulse duration shorter than the thermal exchange time, so it should be less than 3 milliseconds. If I don't want the laser pulse to affect the epidermal melanin, then I have to use a pulse duration above 10 milliseconds or longer than 10 milliseconds, so that the epidermal melanin will absorb the light, convert it into heat, but there will be enough time for the epidermal melanin to thermally relax and release more than 50% of the heat to the surrounding tissue. So in this case, the epidermal melanin is not going to be affected. The same applies for the hair follicle. If I would like to be effective on hair, then I have to use a pulse duration equals to 40 or less, so that the heat or most of the heat is going to be confined into the hair follicle and it's going to be damaged. If we look here, we can see that if we used 5 milliseconds, for example, this can be associated with epidermal damage and can harm the skin, whereas if we use 30 milliseconds, then it is more safe and more gentle on the skin, and it's going to be the ideal pulse duration in certain cases. What about the blood vessels? Even for blood vessels, we might need different pulse durations. So if we are trying to target the microvasculature, like capillary loops in cases of non-ablative rejuvenation, we need short pulse duration, about 0.3 to 0.6 milliseconds. If we want to treat fine telangiectasia, then maybe it's 10 to 20 milliseconds. For spider veins, 20 to 30 milliseconds. For reticular leg veins, maybe 40 to 60 milliseconds. And as we can see, the smaller the structure of the target, the shorter the pulse duration, and vice versa. So it's very important to respect the size of the target and choose the right and appropriate pulse duration according to that. For Q-switched lasers versus the long pulse lasers, the Q-switched lasers are in nanoseconds. The long pulse lasers are in the milliseconds or microseconds. So when we are targeting melanosomes, they are about 1 micron in diameter. The thermal excision time lies in the hundreds of nanoseconds. The Q-switched lasers most likely rupture melanosomes, leading to nucleus or cell damage. So it's a mechanical effect, and that's why we can target dermal structures and dermal pigmentation or tattoos with the Q-switched lasers. Whereas with the long pulse light sources, most likely they damage cells with heat conducted from melanosomes, and that's why they can target only epidermal pigmentation, as by the time we are at the dermis, the heat is going to be exhausted, the energy is going to be exhausted by absorption at the upper layers of the skin. What about spot size? What is the impact of the spot size? For the spot size, we have to understand that the larger the spot size, the deeper the penetration. So if we are using a large spot size, then we can see that the penetration depth is going to be more than if you are using a smaller spot size. If we remember, one of the first slides in this presentation is the laser tissue interaction, where we get reflection, scattering, and absorption, and that's why the deeper we go into the skin, the effect is going to be like an inverted cone. So if we start with a large base, large spot size, then the cone depth is going to be more than if we are starting with a small spot size. This is very important practically, because if we are having a deep structure like a hair follicle which is deep, then we have to use a large spot size to be able to achieve enough energy at the depth of the target. However, if you have a small or superficial target, like in cases of hair removal in the upper lip, usually the upper lip is sensitive area, usually the hair follicles are not very deep, so in this case it does not make sense to use a large spot size. If I use 15 or 18 or 20 millimeter spot size, then the penetration depth is going to be too deep, and the pain associated is going to be too much without any additional benefit. So in this case, it is wiser to use a smaller spot size, which is still going to be effective without any problem. So using the appropriate spot size according to the depth of the lesion makes more sense, and if we are treating large areas, then using a larger spot size for deeper penetration where the hair follicles are deeper is going to be a much better option. What about skin cooling? For skin cooling, we have contact cooling, like application of ice cubes or ice packs, application of ice gel, or use the cold conductor hand pieces like the chill tipped hand pieces, the metal cooling finger, or the sapphire lens. Those are contact cooling methods where we have to make sure that the contact hand piece is going to be cleaned and sterilized in between patients. It's very important to exert enough time on the skin in order to have the cooling spreading to make effect. On the other hand, we have cooling using cold air or cryogen sprays. Of course, cold air is a more economical option because there is no consumable associated with that. It's just the device which is concentrating the air from the room temperature and going through a certain circulation to pump cold air towards the skin. There is no interaction with the laser tissue interaction, so it's not like the cryogen. When the cryogen is sprayed on the skin, it increases the reflection and scattering, so it is not very effective when the hair is becoming thin, or if you are trying to treat very thin vascular lesions, very thin telangiectasia, or in faint pigmentation. So that's why cold air is a preferred way of cooling than cryogen spray. A very common or popular question is the laser in pregnancy. Do we treat pregnant women? No. Actually, we have to know that laser is a coherent collimated monochromatic light. It is non-ionizing radiation, so from the theoretical point of view it is safe. However, I don't prefer to treat pregnant women because if there are any pre-existing congenital anomaly in the baby, we are going to be blamed, and the patients might think that the laser treatment has caused this problem. Another factor which is very important is the fact that during pregnancy there is increased production of melanocyte stimulating hormone, which increases the risk of hyperpigmentation during any skin trauma. So not only limited to the laser, but any wound in the skin might be associated with higher incidence of hyperpigmentation. In addition to that, there are some acupuncture points on the skin which we are not familiar with. If stimulated, it can precipitate uterine contractions and abortions, and the same applies for the pain. If you are treating large area of the body, the pain associated might precipitate uterine contractions, and abortions might happen, especially in the first trimester of pregnancy, and that's why I personally don't prefer to treat pregnant women. What about the operator? What if the operator is pregnant? Is there any contraindication? Actually, no. As long as she is using the normal precautions, using the goggles, not having certain postures which are causing any problem for her, there is no hazards or potential risk of anything, because with the lasers this is non-ionizing radiation, and we don't worry of any potential risk for the pregnant operator, technician, nurse, or physician. Thank you very much for your attention. I hope this was an introduction which is going to help everyone to understand the basics of the laser in a practical way and implement it in the daily practice to improve the outcome and optimize the outcome of the laser practice. Thank you very much.